Hello, everyone. Welcome to a new episode of our podcast, Nottingham Case Series. I am Get Kasous, a clinical fellow in thoracic surgery at Nottingham University Hospital. And today I would like to welcome our consultant, head of department, Mr. Nathan Bensaid. Welcome, Mr. Bensaid, and thank you for accepting our invitation.
Oh, you're very welcome. Thank you for having me. It's always a pleasure to chat.
Thank you. So today we will discuss an interesting topic. It's maybe the most common topic and interesting topic in thoracic surgery. We will talk about early stage lung cancer, and we'll discuss also briefly about lung cancer screening. In the beginning, I would like to say the disclosure that this webinar and podcast is intended only for educational purposes. There is no real patient identifiable information as included, and all images used are publicly available or sourced from open access platforms. So, Mr. Bensaid, this topic is it's very important, of course, for all surgeons at all levels. We are meeting these patients almost every day in the clinics, and we have referrals from MDT always about these patients. So we'll discuss about early stage lung cancer, T1, T2, and 0M0. So let's say that you are in clinic and you have this referral, 68-year-old lady. She is newly diagnosed with 3.5 centimeter left upper lobe adenocarcinoma. Her performance status is 1. There is no significant past medical history. PET CT scan shows stage T2A N0M0 disease. So my first question, how you would manage this patient and approach her?
Yeah, well, the first thing I'd like to say is that it's really wonderful that we actually live in a period that we get patients who are stage 1 lung cancer. Back whenever I was starting my training, this was a rare scenario, but thanks to screening and early detection, this has completely changed the layout of what we see on a normal everyday basis. And seeing these sort of early stage cancers with a single nodule with no nodes is becoming more and more common. It's massively increased resection rates within the UK, and now early stage 1 cancer is starting to become the predominant stage that we're operating on now. So whenever it comes to seeing these patients, the first thing is to say hello and build a good rapport with the patient, because actually having a good communication line with the patient is really important for all future interactions. So building that relationship from the word go the first time you meet them is really, really important. So the patient has lots and lots of options about what we can do here. And the first thing I do is to sit down with the patients and work out, are they fit for these options? And if they are, then I go through them all with them. So the first option is clearly do nothing at all. This is assuming this is a T2A N0 tumor.
So let's say that we have here this scan in front of us, and how you will read this scan, let's say for exam scenario, and what's the...
So the first thing to say this is a single slice of a CT and PET scan, and you cannot make a full assessment on a single slice. Assuming this is the only relevant slide and there's nothing else, then I would say this is a contrast enhanced CT scan on the left in an axial view, demonstrating a well-rounded, potentially speculated on other slices, but on this slide, a well-rounded nodule in the left upper lobe. I'm assuming that I need a bit of time to work out exactly which lobe we're dealing with, but I'm guessing this is in the apical trisegment, although it may be in the lingula. The PET scan shows a single nodule which is hot on PET. We would call this intensely avid, but again, you'd have to see the SUV to know the PET uptake for sure. Mm-hmm. But based on this, you'd say this was a probably T1C, but as you said, it's 3.5 centimeters. It's going to be a T2A and 0M0 tumor.
Well, for this patient, do you need any further investigation for staging?
So if we're talking about a 3.5 centimeter tumor, then there are guidelines that dictate what we should do at this stage. So NICE guidelines talk about nodal staging if the nodes themselves look abnormal and are enlarged by size criteria, but they don't go into other tumor characteristics. And if we look at the ESTS guidelines, they do go into that. And they would say that even if you've got negative mediastinal nodes on your PET scan, if you have a central tumor that is, or a central tumor or a tumor that's greater than 3 centimeters, then you should have investigations and mediastinal staging using either an EBUS or mediastinoscopy. And given that modern technology we use has with the EBUS has improved massively since these guidelines came out, it'd be very rare to use mediastinoscopy as your first choice modality now. Now, if you have suspicious nodes on a PET scan and you get a negative EBUS, then repeat EBUS or mediastinoscopy is a very valid thing to do at that stage. But generally, we wouldn't use mediastinoscopy as a first investigation based on a central tumor or a tumor that's greater than 3 centimeters. Brain imaging would not be routinely indicated in this patient because they've got stage 1 lung cancer, and you'd only go down the route of doing brain imaging if in stage 2 or stage 3 cancers. And NICE guidance talks about doing brain imaging, a CT scan in stage 2 and an MRI in stage 3. Our MDT generally goes down an MRI for everybody, but stage 2 or stage 3 should have imaging. Stage 4 cancers, which this clearly isn't, you don't routinely scan the brain unless they have symptoms, but because there's a good chance you'll find something, but we just don't do it because there's no real curative options in those patients.
Mm-hmm. So let's say that the patient has his friend with him in the clinic, and his friend told you that he watched on social media some videos about treating lung cancer using a new treatment, something like homeopathy or different treatment, but not surgical. Yeah. And he's asking you, like, do you use this treatment here? And what do you think about that?
So new treatments are coming up quite frequently, but there is so much misinformation on the internet, seen in social media channels, and even AI chatbots often giving out things that are just completely erroneous. So the first thing I would do is to go through all the options with the patient, including the option of doing nothing, the option of surgery, the option of radiotherapy. And I would mention chemotherapy at this stage, but in a stage 1 cancer, I would say that would only be used if we upstage tumors. So I would go through what science says and what all the medical evidence would point to. If they still persisted in talking about homeopathy, it's a patient's choice. Now, the first thing in this scenario you need to exclude is there coercion by the partner to the patient. And so it's important to have an interaction with the patient without that partner there, who could be coercing them, saying that they have homeopathy. And you'd want to explore the options or the reasons why the patients want to explore this well. They may find that caring obligations would mean that surgery is too difficult to consider at present, or the complications of having to come up to the hospital to have saber radiotherapy is too much for the patient to go through. And there may be things that the hospital can offer to help the patients get through this difficult time to get curative treatment. And they may be raising homeopathy as an option because they know they can take that at home and it won't impact their life. One of the important things to go through is to make sure the patients are aware that if they are going down a holistic medicine approach where they're talking about homeopathy as an option, we need to tell them that there's no evidence that homeopathy can cure lung cancer, and the only things that would really cure lung cancer as stage 1 would be surgery or radiotherapy. After a long conversation, after discussing all these areas, addressing all the patient's issues, concerns, and expectations, essentially you have to obey the patient's autonomy. So if this patient has the ability to make that decision, you have to let them make the decision. And you have to let them go down even a destructive route that would end their life, as long as you're happy they can make that decision.
Let's say that in the clinic, the registrar, and I had this discussion with the patient, and they, let's say, insist to do something like homeopathy or something like that. Of course, I should in that time call the consultant or refer back to the MDT as a registrar? What do you advise me to do?
So the consultant would need to be involved in that conversation, because essentially in a clinic, the ultimate responsibility will fall on the consultant to make that decision. So the consultant needs to be there. They need to make sure the patient fully understands the risks that they're exposing themselves to from an autonomy point of view. The patient themselves might not see it that way. They may see that homeopathy is the complete answer, and they may be in denial about that, but the consultant needs to make sure that the patient has been fully informed of those decisions. Once that's the case, you need to bring it back to the MDT. The MDT shouldn't make a different decision, because the MDT is there to make a decision about the patient based on their scans and their test results. So the MDT decision would still be for surgery or radiotherapy, not for homeopathy. Mm-hmm. But the MDT can't overrule the patient's own autonomy.
Okay, let's say that they convinced that surgery is the right or saber. They are the reliable options. Yeah. So how you will counsel this patient? As you said, you will offer them doing nothing, then surgery and saber. So how you will counsel them? What's the risk you will mention to them?
So this is a difficult topic. So I go through the results of surgery with the patient, and I generally quote them the national outcomes. Now, these were recently reported at our society meeting, which show that in this scenario where you've got a primary tumour of the lung with no evidence of spread, and you would probably do a straightforward either robotic or VATS lobectomy, you're going to be quoting in hospital mortality rate of less than 1% based on national outcomes. So usually that's enough to convince the patients that that's the right choice to go for. Now, as a surgeon, you should be talking to the surgical risks and benefits and not to the radiotherapy risks and benefits. And so that can actually be tricky for a patient to make a decision. And so usually the best approach is, if the patient's having difficulty making the decision, is to have both radiotherapy and surgery potentially in the same room at the same time discussing these. But from a surgical approach, I would have a good chat to the patient about the surgical options. So to talk through the three primary routes of surgery, which are VATS, robotic and open, and to say what each one would apply and when each one wouldn't. So in an early stage tumour such as the scan, we would be talking about a minimally invasive approach as opposed to an open approach. And certainly in Nottingham, our minimally invasive rate is about 90%. So the vast majority of our cancers are taken out through a minimally invasive approach. Some centres have higher open rates, but in an early stage cancer, I think the evidence says that we should be doing minimally invasive surgery. There's a few trials that talk to this, and we can talk about these if you like.
Yeah, what's the most important trials that we should know as registrars for the exam?
Every centre will have really good evidence from their own patient cohort looking at open and minimally invasive and comparing the two outcomes. There is one big trial that was published in the UK looking at this called the Violet trial. And this was a randomized control trial published in the New England Journal of Medicine that looked at comparing a blinded study comparing patients who've had keyhole with open surgery. And they found that minimally invasive surgery had a faster return to normal, fewer complications, and a shorter hospital stay. It's a really important trial, and before any major examination, you should be reading that one to know what's going on and the outcomes from it. That being said, I think one of the big take-home messages from the Violet trial is that open thoracotomies have got much better than they used to be. And the length of stay for a thoracotomy was only counted as 4.5 days in that trial. So whilst overall costs for both the patient and the hospital will be less with a minimally invasive approach, I think it showed that an open approach isn't a disastrous approach if needed. There's no good trial comparing VATS with robotic surgery. And again, we've got lots of anecdotal studies and a few studies that show that there's higher nodal yield harvest within VATS cohorts within RATS cohorts instead of VATS cohorts. But I think the numbers that you would need to prove a difference in survival would be too much to be able to carry out a randomized control trial.
And I believe that, the trials in comparing rats to VATS, they show that more lymph node, harvesting with the rats, but there is no nodal upstaging was.
Yeah.
And as you said, that there is no evidence so far to reflect on survival or the recurrence. There is no oncological outcomes so far.
Well, certainly going back to those national outcome data, the outcomes from a robotic lobectomy and a VATS lobectomy are within 0.01% of each other. So they're really, really close in the long-term outcomes. So you don't get a an inherent survival advantage from having a robotic lobectomy over a VATS lobectomy.
So let's say that this patient agreed to have a surgery by keyhole, and what the type of resection you will offer for this patient with, let's say in this scenario it's 3.5, but let's say that you have a patient with 2 centimeter nodule.
Okay, so if you're talking about a sub 2 centimeter tumor, then we get into the realm of sublubar resections. And this is a really contentious topic at present within our trial, or within our society. Classic teaching has always been that if a patient is fit for a lobectomy, they should have a lobectomy, as it gives the best survival advantage. And this goes back to years of older studies comparing the two. But this all got blown out of the water a few years ago whenever 2 landmark studies were reported. One called the JCOG 0802 trial and one called the CALGB 140503 trial. They're super catchy titles. But they looked at this breakdown of lobectomy versus sublubar resection, either segmentectomy or wedge in the case of the CALGB trial, but only segmentectomy in the case of the JCOG trial. And they compared lobectomy with these sublubar resections and found that there is no survival advantage with lobectomy. And in fact, the JCOG pointed towards a overall superior survival with segmentectomy. Now, these were the initial outcomes, and they did raise that there was a slightly higher recurrence rate in the JCOG trial, but the initial outcomes showed a survival advantage with the minimally invasive trial. The updated outcomes have just been reported a few months ago, and they've shown that at the 10-year point, survival with lobectomy appears to be better, or at least on par with segmentectomy. And what we're seeing is a double the rate of local recurrence in those patients. And so what the outcome for that should be, it really means is you have to pick your patients, and in a patient that's going to be healthy and live for a long time, I believe they should be offered a lobectomy in that scenario.
Even for tumors 2 centimeters.
Even for tumors 2 centimeters.
It should stay the standard of care.
I believe so, based on these, but this is again a really contentious issue at present. And there will be surgeons who are probably cursing me under their breath for saying that. Doing a segmentectomy does offer advantages in the realm of better FEV1 in those trials, but actually the difference in FEV1 outcomes was marginal, and they probably don't have a real world benefit for the patients. The authors of the trials said that they think they probably measured the wrong thing with FEV1 and thought about doing VO2 max, but there's lots of different topics lots of different aspects of this you could look at to see whether one is better than the other. I think overall patient function is probably the best outcome, and just doing patient quality of life questionnaires. But again, this is another largely debated topic about what the right investigation to look at how patients do with their surgery. What the best outcome measure is.
So we should give the patient the options and tell them the evidence about both types of resection, and it's at the end it's a shared decision for patient and surgeon.
So to be honest, most of the patients you see in clinic will say, do what you think is best, and they put the onus on to you as a surgeon, because whilst they may be very competent to make a decision and have the capacity to make a decision between a surgery versus radiotherapy versus nothing, they may not have the ability to make the decision between segmentectomy versus lobectomy. And I think that's reasonable to take a patient and do what you think the right thing is for them. for me, the right thing in most of these patients will be lobectomy unless they're compromised patients, whenever a sublobar resection is probably the right way to go.
So let's say, I know that you are choose to go with lobectomy, but the patient, he would like to go for segmentectomy.
Yep.
And after on pathology, the pathology came back as the tumor is now not 2 centimeter, is now, let's say, 2.5 centimeters. So there is upstage in T stage, and sometimes we have upstage in nodal disease. So for these patients, do you offer them to come back for completion lobectomy? Or what is the proper approach for them? I know it's also debate on that topic, but how should approach this patient?
So again, this is a difficult scenario. So if you've got an R0 resection, I'll offer the patient the option of completion lobectomy, and I think I've yet to have a single patient take me up on that. Most of them are happy with a margin, even if it's close to getting it out. The general rule of thumb is that your margin should be the same size as your tumor. So if your tumor is 2 centimeters, you should have a 2 centimeter margin. But I've yet to meet a patient who has wanted me to go back and do a lobectomy whenever I've had a 1 centimeter margin instead of a 2 centimeter margin. But it's a reasonable thing, and I definitely would strongly consider a completion lobectomy if the margins were close, if the tumor is greater than 2 centimeters and the patient's very fit for it. But it has to be a really nuanced, individualized discussion where you're balancing the patient's fitness and the damage you'll do by going back versus the risk of it coming back, which will be small. If there's nodal disease found, then I think the survival for that patient comes in the form of systemic therapies. And so I'm not massively keen to take the patient back if you find nodal disease. I think the better thing for them survival-wise is to get on and have systemic treatment as soon as possible.
Okay, let's say the patient asking you about alternative treatment, and here we talk about SABR, for example. So what evidence do we have about SABR comparing to surgery?
So again, this is a hotly investigated topic that's been looked at over and over again. There's a large study I think it was published in about 2016, but I would have to double check, called the Sabertooth trial. And this compared surgery it was a feasibility study to see if it's possible to do a randomized control trial looking at surgery versus SABR. And it found out it wasn't possible to do that within the UK. It said the UK didn't have a high enough patient or a high enough disease burden to do that, and it would have to be a multinational study. That study, though, did do an analysis, a subpart analysis, looking at the two groups, and said that they had comparable short-term outcomes. There was then another study called the STARS and two studies actually called the STARS and Russell analysis, and they looked at the paper. These were then they were both sub-recruited, so they weren't able to answer the question, and then they did a pooled analysis of this. But again, even the pooled analysis of all the data from both studies was subpar, and they showed there was a similar overall survival. If you drill down into the data even more, though, they had patients who died on the operating table and things like that, and so the actual study doesn't look like it was completely comparable with real life. Now, there is a study that's just been reported at BTOG, and that is a study called the SORT trial. This is hot off the press, and it essentially looked at an NHS National Cancer Registry data for all patients who are T1 or T2 and 0. And they picked up all patients between 2015 and 2020, essentially all ages, and they stratified them all, and they found that surgery has better outcomes with the all-cause mortality was better in the surgery group. So if you looked at the 3-year mark, they found that the all-cause mortality in the SABR group was 39%, and compared that with surgery at 19%. And that's a massive difference of essentially 20 versus 40% mortality rates at 3 years. And so in that study, surgery was strongly favoured, but that wasn't a true randomized control trial. It was what's referred to as a statistical randomized trial or a computed randomized trial. But that that hasn't reached print yet, but I'm very interested in reading the final wording of the paper.
Good.
Generally, though, surgery is considered the gold standard treatment for lung cancer, with radiotherapy saved for patients who are unfit or do not want surgery.
Well, let's back to the scenario from the beginning. Let's say that this patient didn't have a diagnosis and he presented to you with this incidental finding of lung nodule. And especially with the screening, there are increasing number of patients with new lung nodules, GGOs as well. So do you biopsy all of these patients? How do you choose your patient for biopsy based on which criteria?
Yep. So firstly, patient choice comes into this massively. Some patients can't tolerate the idea of having any sort of tumor within them, even if there's a good chance it's not malignant. But one of the first things you need to do is to look at your PET scan and calculate a Herder score. The Herder score it's quite an old calculation now, but it's used to estimate the probability of lung cancer, and it pulls on various patient-related features and tumor-related features. In the case you've surmised, I would estimate this patient has a very high Herder score, but we'd have to enter everything. The general rule of thumb is that anything over 70%, you are able to take to theatre and remove the tumour on a diagnostic means. But looking at this from a patient point of view, there's some patients who 70% is too low. There's some patients that 95% chance of it being a cancer is too low and they want 100% certainty. And in those patients, you definitely take them to theatre. The original scenario you've given of a 3.5 centimetre tumour leaves a very interesting point of investigation, and that's because any tumour that's above 4 centimetres, we would offer chemoimmunotherapy, and you need tissue to be able to offer that because you have to exclude patients with EGFR markers. And so in a 3.5 centimetre tumour, you don't have that particular need. So in this scenario, patients would always be would go first line into a treatment of surgery or radiotherapy without having immunotherapy first. And so that's not a question. But if your tumour is above 4 centimetres, we would suggest that everyone needs a biopsy before treatment. Biopsies can be done in lots of different ways now. The classic way is a CT-guided biopsy. And we believe that any patient who's able to have a CT-guided biopsy before surgery should have that done if they need a biopsy. There is another option that we do in Nottingham called an ion biopsy, and that's where, or a robotic-assisted bronchoscopic biopsy, and that's where we get the patients under a general anaesthetic and pass a catheter using guided instruments right out to the nodule to biopsy it. We would reserve this for patients who can't have a CT-guided biopsy and still need to have tissue diagnosis before surgery.
Mm-hmm. Well, and what is the success rate of ion bronchoscopy comparing to the CT-guided biopsy? Like, what's the accuracy, let's say?
So again, this is very user-dependent, and what our preliminary results with ion are incredible. So we've just submitted our first 100 cases for publication, and they found a sensitivity of 94% sensitivity. But this compares favorably to most centers that do CT-guided biopsy, which sensitivity on average is somewhere in and around 85%. But it doesn't need a general anesthetic, and ion bronchoscopy does need a general anesthetic. So often that's the right choice to go first, and then ion if you can't get it that way.
Mm-hmm. Well, thank you, Mr. Ben-Said, for this interesting discussion. It's an interesting topic, and there are a lot of new trials, discussion, and debate about this topic. We planned initially to speak about screening, but we don't have time today to speak about screening, so we'll do a different podcast for this topic. And thank you so much. I learned a lot today from you about SABR and how to approach patients, because as you said, relationship with the patient is very important for surgeon, and to build confidence and trust between patient and surgeon. So it's important to know how to deal with the patients and approach them and explain them treatment options. Thank you so much, and thank you for your time.
Yeah, thank you, and I'll look forward to the screening talk.
Thank you.